Yeah.
We are
Good
live.
evening, Dr. Aarti. Good evening, Usha ma'am.
We are
Good
live.
evening, sir.
We are live now. I will. Good evening, everybody. I will start my presentation. behalf of National Society of Manual Small Lesion Cataract Surgery, I, Dr. Anil Shah, President for Maharashtra Chapters, welcome all the delegates, speakers, discussant on this wonderful series of webinar that is A to Z of MSICS. Today is episode 3 and the topic for today is infection control, our aim. There are various factors which are responsible for infection: patient selection, pre-operative preparation, sterilization, OT management, improper intraocular fluid and drugs, septic focus, poor post-operative management, hospital devices, impure water, contaminated surface, airborne infection, hospital staff. When infection occurs, no time is left. It is an emergency. Infection control is everybody's responsibility. It is said that prevention is better than cure. True prevention is not waiting bad things to happen. It is preventing things happening from the first place. And there lies the importance of sterilization of surgical equipment, management and organization of operation theatre. So for this topic, we have speakers who are expert in their field with the best of their knowledge and experience. We have Dr. Purvasha Naran, Dr. Bhaskar Kher, Dr. Uday Rajiwala. And to discuss this topic, we have eminent faculty member Dr. Vaishali Bune, Dr. Naina Poddar, Dr. Ravi Tehran, Dr. Anik Mavilambe. They will provide professional and constructive criticism. They will raise issues related to the presentation, which will be helpful for students, and we have a vibrant webinar. So for this series of webinar, our aim is to popularize smart SICS. It should be safe, cost effective, with minimum learning curve, and it should be useful for community basis. So our mission is to conduct series of webinars to enrich the knowledge, to popularize SICS from basic to advanced, to give recent advances to postgraduate students and practicing ophthalmologists, to involve expert surgeons to share their experience and knowledge, to make SICS interesting and a popular technique. I am thankful to all of you. Please join our next episode 4. The topic is Know Your Surgical Instruments on 26 July 23. Thank you very much. Thank you, everybody. Now I will hand over to Dr. Aarti. She will talk about, she will hand over to Aarti. Is there?
Yeah, good evening, everyone.
Good evening.
Thank you so much, Dr. Anil sir and team, for starting this webinar series, which is going to be very useful for all of us. On behalf of core team of ISMS ICS, I would like to welcome all of you. Dr. Sahu and Dr. Buramani will be joining us shortly. We have with us Dr. Parikshit Kokte sir. We would like to hear some words of wisdom from you, Parikshit sir.
I think we have great speakers today who will be giving us words of wisdom. And I think it is Dr. Shah's foresight that it's not just the surgical technique that is important, but all the preparation that goes before the surgery starts, during the surgery, and even later too. I mean, with modern antibiotics and with all the proper asepsis, the incidence of endophthalmitis and cataract surgery has fallen to less than 1 in 5,000 or 1 in 10,000. But it is still one of the most dreaded complications in cataract surgery. So I'm glad that the Maharashtra chapter of ISMS ICS is taking forth this very, very important topic with stalwart speakers. I mean, we have Dr. Khaire here, who's just been adjudged one of the best deans of the government medical colleges in Maharashtra. Out of the 34 medical colleges, he was adjudged the best dean in Ambezogai. And Dr. Uday Gajiwala has had, publications and guidelines on infection control for the last 15, 18 years. And through Sight Savers International and other international agencies, he has been very, very active in this field. So I must congratulate Dr. Shah and all the team so that we have such excellent speakers over here. And of course, our new young experts who are stalwarts in their own right and famous professors who are doubling up as panelists. So we are all looking forward to a very exciting and a very informative discussion. Thank you.
Thank you so much, sir. Yeah. So without the further delay,
Dr. Ruchita, I think she has words.
Yeah. I'll start. Good evening, everybody. I'm Dr. Ruchita Machwe, Executive Committee member of ISM SICS Maharashtra chapter, and I welcome you all for this third episode. As we all know, in ophthalmic surgery, meticulous asepsis is of paramount importance, and hence this webinar. So in this webinar, we shall see how to have control and proper monitoring of our OT instruments, OT, as well as quality control. So for this, we are lucky to have senior ophthalmologist as our chairpersons. I'll share my PPT. Just one second. Is it visible?
Yes.
Yeah.
Yes, we can see it, ma'am.
Yes.
Yes, we
So
can
our
see.
chairperson, Dr. Adesha, who's the president, ISM SICS Maharashtra chapter. He has got research awards from MOS for SNARE, and he's very well known all over India and internationally for this innovation. He's published a lot of books and master guide of MICS, international presentations, surgical demonstration, and paper presentations at national levels. Can you see the second?
No.
It's not moving. Mr. Sunil, can you share, please?
Yes, ma'am, I'll share.
Somehow it's not moving on. I'll stop sharing.
Dr. Anik has also joined.
Welcome, Dr. Anik.
Thank you. I'm here.
Welcome,
Welcome, Dr. Anik.
Thank
Welcome, ma'am.
you. Thank you very much.
Mr. Sunil, are you sharing?
Yes, ma'am, I'm just sharing again. Is visible?
And Dr. Jignesh Taswala, who's immediate past president MOS, past president POS. Then he is got international conference coordinator for MOS at various international places. He's honorary reviewer of AIOS Scientific Committee, and he was awarded Doctor of the Year award by Pune Congress. Our third chairperson, next slide, please. Dr. Shekhar Paranspe, sir, He's scientific committee member of ISMSICS Maharashtra chapter, interest in anterior segment eye surgeries, and he has worked relentlessly for eye donation movement. He's a private ophthalmic practice surgeon in Sangli, Maharashtra. Next, please. Dr. Shirish Thorat, consultant ophthalmologist from Akola. He is the incoming president of Vidarbha Society and vice president of Maharashtra Ophthalmic Society. Next slide, please. Now we have got eminent speakers with us, Dr. Purvasha Narang, who is a corneal and refractive surgeon with rich hands-on experience on all lamellar keratoplasties and ocular surface reconstruction surgeries. She is currently associate professor in Department of Ophthalmology in AIMS Nagpur. She's ex-senior consultant cornea, refractive and ocular surface services, Ambala, associate editor of Journal of Cornea and Ocular Surfaces. She has got national and international presentations, reviewer for international and national peer-reviewed ophthalmology journals and publications in PubMed Index journals. She has received Inspiration in the Field of Cornea Award 2021 from Women Ophthalmologist Society. So welcome, Dr. Purvasha. Our next speaker is, next slide please, Dr. Bhaskar Khaire. Is Professor Dean SRTR Ambezogai. He has got PG teacher experience for 30 years. He's got Best Paper Award from MOS, Best Teacher Award by MOS. He's an outstanding teacher and he has got received award by ISK RIS. Special interest he's having in oculoplasty. Next one, Dr. Ujay Gajiwala from Ahmedabad, Superintendent Tejas Eye Hospital, which is run by the Divya Jyoti Trust. He's got publications in international peer-reviewed journals, and he has authored a manual on infection prevention. He's Vice President ISMSICS Gujarat chapter. Next slide, please. To make these presentations and discussions more interactive, we have invited senior ophthalmologists who will be discussing after the speakers' presentation will be over. Dr. Vaishali Une is the HOD from Dhule. She's got a lot of international publications and she's chief instructor in state conferences for SQUINT since 4 years. And she's past president of Aurangabad Ophthalmic Association. Next, please. Dr. Ravi Trehan from SP Medical College, Bikaner, is a solo practitioner from Rajasthan, national coordinator of ISMSICS, and main interests are SICS, TICS, Smart SICS, basics of personal finance, spirituality, as well as reading. That's very interesting. And we have here Dr. Naina Potdar from AIMS New Delhi. She is an API ICO. Professor HOD from Nair Hospital, Mumbai. She has got tremendous experience of PG teaching for more than 25 years. She has got various publications, national, international. She's LDP alumni. She was MOS scientific committee member, ex-zonal member, past executive member, ISM, SICS, and she's got special interest in community outreach program, and she runs mobile ophthalm van. Next, please. We invite Dr. Anik from Congo. Welcome, madam. She's completed studies from University of Kinshasa, postdoctoral fellowship in uveitis. Her mission is to develop network of modern ophthalmology clinics nationwide with the help of competent specialists using modern technology. Next, please. Now we welcome our first speaker, Dr. Purvasha. You can start sharing your presentation. She'll be presenting on cleaning, packaging, and sterilization methods for ophthalmic instruments. Welcome, Dr. Purvasha.
Thank you so much, Dr. Rujuta. And at the outset, I would like to extend my gratitude to the entire team of International Society of Manual SICS Surgeons, as well as Dr. Professor Rajesh Joshi sir and Dr. Anil Shah sir. Thank you for letting me be part of this webinar. And I shall be taking you through the cleaning and sterilization of cataract surgery instruments with special emphasis on SICS instruments. So let us just begin by asking all the cataract surgeons present here, what would be their choice or their most important gadget related to the ophthalmology OT? Would it be the fancy operating microscope? Would it be a video recording system with 3D viewing? Or would it be a Mercedes type phacoemulsification machine? Or would it be the humble autoclave?
Autoclave is the important thing.
Thank you so much, sir. So without this particular device or machine, I think having any of these above ones would be absolutely ineffective. Otherwise, we would, after an uneventful, beautiful cataract surgery, the post-op day one would look like this, and we would be suspecting some kind of endophthalmitis, and worse still, if there is a cluster. And of course, something like this, which is a toxic anterior segment shock syndrome, where there is limbus to limbus corneal edema along with fibrinous reaction, intense inflammation, hypopyon, and secondary glaucoma and post-operative severe complications. So based on this, I think it is very pertinent to know the importance of safety or disinfection in our scenarios. So let's see, cataract surgery is one of the most common globally performed surgeries, and India leads with more than 5.1 million patients annually being done here, and not just in volumes but also in quality, because our post-operative endophthalmitis incidence is almost 0.02 to 0.04, as has been reported by a very high volume center, the Arvind Eye Care System, which has performed almost 5 lakh surgeries till now. So what exactly, why are we talking about sterilization procedures specific to cataract surgery, and why not the other organ systems? So basically, cataract surgeries are shorter in time, as compared to the other general surgical procedures. There are higher volumes. The instruments are very tiny, microscopic almost, and they are not heavily soiled from tissue or bacterial contamination. And even if we use minute amounts of detergents or chemical contaminants, they can cause havoc inside the eye, as against the other body cavities, which do not cause so much of inflammation. So basically, the sterilization procedures have to be optimized based on the ophthalmic needs. And the most important cornerstone is safety in the quality. So safety is the foundation of quality, and that has to be impressed upon by the operating surgeon as well as the entire staff. And usually in our practices, it could be ideally done by the central sterile services departments. But if we are not having the facility in our tiny clinics or in our individual standalone practices, I think the knowledge of this at least should be the most important or the critical step for everyone. And sad to say, but this knowledge is generally not very adequate, even though our postgraduate system and education system is robust regarding the surgical part of it. But even during our post-graduation or our fellowships, not enough emphasis is laid upon the safety and quality of sterilization. And sometimes queries like these turn up in many situations, and we don't have the answers to them. Why should we do the proper cleaning? Who should do the cleaning, packing? When should we do it? How do we do it? Is there a need to follow separate protocols for solid versus hollow instruments? How do we achieve sterilization in between cases? How do we monitor the processes? And how can we store the autoclaved items? What happens if I drop a critical instrument during surgery? What if I receive a wet pack after autoclaving? How do we go ahead with cases which are seropositive? And finally, basically, any of these queries remain unanswered in the young minds. So it's very pertinent to know how to go about the sterilization and disinfection of your surgical part. So what exactly is sterilization? It is a chemical or physical process which takes care of all microorganisms, including spores, and kills them. Whereas disinfection is basically reducing the number of microorganisms. It does not take care of the spores. And the most important critical part of disinfection, the process which is important, is the cleaning and disassembly in the beginning of your process of the entire journey of sterilization. So this is the most important part, followed by, if you have the ultrasound cleaner, then followed by the washing and rinsing, along with drying of the instruments, the proper packaging, as well as loading in the steam sterilizers. So if we have to look at the process from the beginning, when do we start is absolutely immediately after the surgery is over, we try to as soon as the case is moved out of the OT, the instrument tray has to be dealt with by the scrub nurse. She will, or he or she shall basically segregate the disposable items from the ones that have to be reused, and all the sharps and other materials which need to be disposed have to basically follow the protocols of the biomedical waste system and taken care of, whereas all those which are present which have to be reused and sterilized have to be taken care of individually. So the solid instruments have to be separated from the hollow instruments, like the fine instruments like limbs, the vanas, the suture tying, the bridle holding forceps, the McPherson's, the Utratas, capsulorhexis, as well as the larger instruments like sponge holders, bowls, trays, artery forceps, scissors, as well as the cautery tip, which is used for conjunctival flap making before the small incision cataract surgery incision is made. So all these basically what you have to teach the circulating the scrub nurse is that proper observation and inspection of these tips has to be done either with a moistened lint-free cloth or piece of cloth which is sterile, and that all these tiny crevices, hinges, these serrations all have to be cleaned properly, and any inorganic or organic debris which is present has to be immediately removed. It could be in the form of viscosurgical device or the visco present over the surface, which can dry up and then later cause problems in sterilization. Inadequate sterilization is caused. Otherwise, blood or lens matter, any of these materials can lead to ineffective sterilization. So this has to be properly removed. And so is it's also important that we take care of the hinged instruments. The scissors have to be disassembled. Anything which is assembled has to be taken apart and then placed in the tray and then passed on. So next is, what do we do? This is the hatchbox, or this is the system which we have to follow. And one side of the sterile side of the hatchbox is opened, and then the tray is passed to the other side. And once the door is closed, only then the tray can be taken out from the other side or the decontaminated side of the septic zone. So and this has to be done again wearing gloves. So this is the passage of instruments through the sterile area to the unsterile area for further processing. For those hollow instruments like Simcoe's irrigation aspiration cannula, AC maintainers or Blumenthal technique, irrigating vectors for nucleus delivery, your hydrocannulae, or for that matter, other hollow instruments, you have to first flush them properly. And that is done by distilled water, not just tap water, but it has to be done with distilled water, because tap water usually is known to carry endotoxins and other contaminants which are seen and which have been found. So it's always better to flush it with distilled water. Deionized is better. And that flushing is again done using a 20 cc syringe, and 2 to 3 times each instrument, each hollow tube is flushed, and then followed by that we have to push in air. So after the distilled water is used, then 2 to 3 cycles of flushing with air is done, and then the instruments are placed in the tray and then passed on. If we have the ultrasound cleaner, like in our institute, we use that. So for that, we can use the instruments are placed in the tray and then lowered immersed into the water in the ultrasound cleaner and covered with a lid. And this is basically then run for 15-minute cycle at 50 degrees centigrade. So this is basically the ultrasound cleaning of these microscopic instruments. After this, we need to rinse and flush again, because any debris or organic material which is dislodged should be rinsed off. And this is done using RO water. And then the instruments are again placed in a clean tray, after which they can be placed on a clean cloth, and we use usually the hair dryer for drying up these instruments. The bigger ones can be cleaned with sterile cloth, but the tiny ones are better cleaned with the hair dry, dried better with the hair dryers. And then comes the step of packing, where each instrument is placed back into the tray, and there, along with the rest of the instruments and the hollow tubes also, we would like to place the type 4 indicator or the type 6 indicator inside the tray. So that would be the first indicator that we place. The ones which are bigger instruments, they can directly go through the hatch box out, and then they are washed, and then they are packed in separate drums. And that is how you have to clean and pack them. Now, if we look at the if there's no availability of the ultrasound cleaner, the other way to do it is probably the chemical disinfection some people practice by using the aseptic solution, which is the chlorhexidine and the cetrimide solution along with isopropyl alcohol, in which the instruments are dipped completely into that for a few minutes, and then with the gloved hands and a brush which is used to clean the tip of these instruments, which is again submerged in the liquid itself while cleaning, so that there are no aerosols created or generated, and then they are placed for rinsing and washing under tap water. And again, after this is placed again in distilled water to prevent any corrosion or rusting of these instruments. So after placing them in the distilled water for 10 to 15 minutes, again, they are placed on the clean cloth, and then they are air dried for further packing. Again, this is the type 4 indicator which is placed here, and as you see, this kind of pink dot will turn to black if once there is proper sterilization, which is indicated by the change in color. After this, we prefer to follow the technique of double packing of these instrument trays. So this tray is now placed in the 100 by 100 centimeter cloth, which is porous for the steam to pass through it. And this is the method that we follow. We just fold the cloth into layers. And this is the first packing which is done. After which the type 4 indicator is again placed, and this is placed over the second cloth, and this now is ready for the second cover of the pack. And this is packed in such a way so that it is easy to open. And over that, this type 1 indicator tape is placed to show if the sterilization has taken place once it goes into the cycle. So this is the way to mark it. We should all have our sets marked with the permanent marker, and you have to make sure that the date and the time of setting this up for sterilization is sent. So once this comes back, these brown lines will turn black, showing effective sterilization. The next ones are the microscope knobs and handles. If you see, they can also be cleaned with they can also be disinfected by placing in the towel and packed in those clean towels. And so is with gowns which come from the facility. They are folded and packed. 2 gowns each, along with hand towels and eye sheets are basically packed together. And again, a type 4 indicator is placed, and this is again packed and marked. And what about iPads, cotton gauze, and buds? Yes, we can pack these too. And these are packed in tiny lint-free tissues. And these are again placed in green sheets and packed in the drums. And this is now the trolley ready for transportation towards the Central Sterile Services Department. And in case it is far off, then we have these covered trolleys which prevent any further contamination of these trays and drums. This is the view of our autoclave system, where we have the trained technicians taking care of all these processes. And on to your left, you see a very heavily packed autoclave, the steam sterilizer, which has been very densely packed, whereas on the right is the right way to set the instruments inside, and it should be enough so that to allow the steam to be passing through the sets. The heavier ones are placed at the bottom and the lighter sets are placed on top. And then the lid is closed and sealed properly, and the temperature is set to 121 degrees, 20 psi for 20 minutes, 20 to 30 minutes. And this is the way to start your steam sterilization process. So this one is a pre-vacuum. This one will have 3 cycles of pre-vacuum along with the holding time, and then the post-vacuum and drying cycle is present. So almost an hour of this process takes place. And then after the pressure has all settled and the temperature has come down, then the instrument is opened, and then the packages are taken out, and then they are ready for transportation. So if you see here, the tape is showing those black stripes, which shows effective sterilization. So these packs are now ready to be transported, and it would be better if we place a plastic sheet on top of them while transportation to the operation theater. Now, once they reach the operation theater and they're ready for use, then they can be taken directly. Otherwise, if you have to store them overnight, then there has to be a clean area for their storage. And once they reach the operation theater, the circulating nurse can place these trays, the needed tray onto the trolley, and the first cover can be opened by the circulating nurse. However, after checking for sterility by checking the effectiveness by the indicator, the second instrument tray cover has to be opened only by the scrubbed nurse, as you can see here. And this is the way in which the instruments have been taken out. And now the plastic sheet or the drape has been placed on the trolley, and now the instrument set is being set. So for overnight storage or for storage of these packed instruments or autoclaved ones, it has to be done in the theater area. Preferably, it should be safe, dry, and above the floor level and away from any source of water. Packages should also be checked once before utilization if the seal is intact. So if the tape indicator also acts like a seal to show you if it has been tampered with or if it has been opened, and the sterilization indicator has to be proper. The expiry date should not have been passed, and the staff must notify if any kind of breach in the sterilization or in the sepsis has taken place. And this is the typical sterilization register which has to be maintained. You have to place these strips along with the indicators mentioning the date, the time, the lot, the name of the technician, the name of the in charges. Everything has to be mentioned serially. These are the various types of indicators used. And for batch monitoring, we can use the Bovie-Dick test before sterilization in the morning of all the autoclave processes taking place. And once a week, you should also try and put in the biological indicator to know the efficacy of the system. A word or two about the flash autoclave or the immediate use steam sterilizers. Yes, they are there, but it's not exactly for ophthalmic use that they were built. They have more use for dental and other ENT surgeries. And for us, basically, it is not recommended as a routine. These are only to be used as an emergency measure, just in case an instrument falls off while doing surgery or something critical has come up, or some rep has got your instrument immediately and it has to be used. Only in those cases, unwrapped instrument has to be put in these, and that has to be sterilized accordingly, and it has to be in the operating theater itself, and it should not have a very large transit time or area or environment. So it basically has a very limited role, but it is essential sometimes in emergency purposes. It is not a substitute for multiple sets. So we should invest in having multiple cataract sets in case we need, and this is not for case use. Another thing that people talk about is sterilization for seropositive cases. So some institutes, they follow that just after the case is over, all the instruments are just passed into the first cycle of autoclave directly, and only after they are autoclaved first, then they start cleaning and rinsing and flushing all those instruments. And the basic rule is that use as much as disposable instruments and other supplies possible for these cases. And only after these are done, then the second cycle of autoclave is started. So basically, a double autoclave has to be used for seropositive cases like HIV and HPSAG or HCV, if you've taken that case as the last case of the day. So just trying to share a few sterilization protocols which are used at Arvind Eye Care System, because it's a very high volume, high cataract load system with a very minimal endophthalmitis rate. So I think that deserves an applause. So what do? Just on the day before surgery, they pass these instruments in a packed state in a long cycle of the steam sterilization with a temperature of 120 degrees for 45 minutes. So basically it takes 2 hours and an additional 75 minutes for it to the total cycle to take place. Whereas in between cases, what do is the short cycle sterilization of 134 degrees for 17 minutes in total. So they have this kind of a procedure where they reuse multiple things, but because they have these stringent protocols, they are able to manage with very little endophthalmitis rate or incidence. So just to summarize, the optimum cleaning and sterilization procedures for cataract surgery have to be followed, and appropriate staff and trained staff should be employed and should be monitored. Physicians have to exercise the best clinical judgment in establishing which instrument has to undergo which sterilization process, and maintain the safety and monitor regularly and never compromise on safety. Thank you so much.
Thank you, Dr. Purvasha, for a very lucid and wonderful presentation. All the details were meticulously covered. Thank you so much. We first have all the speakers present their presentations, then we'll take question answers. So I welcome the second speaker, Dr. Bhaskar Khaire, and he'll be speaking on management and organization of ophthalmic operation theatre. Over to Dr. Khaire, sir.
Good evening. I am audible?
Yes, yes.
Hello.
Yes, audible, sir.
Yes,
Can you hear me?
Yeah, very clear.
Yes. At the outset, I would like to thank Dr. Rajesh Doshi and Dr. Anil Shah sir for giving me this opportunity to be the part of this webinar. My topic of presentation is organization and management of ophthalmic operation theatre. So I will be covering the objectives and planning in the planning of operation theatre, layout and design of the operation theatre, equipments used in the OT, the operation theatre protocol, various sources of infection, and what are the standard universal precautions that are to be taken. As we know, an operation theatre is a facility within a hospital where surgical operations are carried out in a sterile environment. Outcome of surgery will depend on the proper organization and management of OT. The various objectives behind the planning of operation theatre, they are we want to promote the highest standard of sepsis, to ensure the maximum safety for the patient and staff from the installation hazards. We want to optimize utilization of the OT facility and stop time, smooth and effective functioning of the OT, creating best workplace environment for the doctors, and allowing flexibility by use of multiple operation suites. The design and planning of operation theatre complex will need compliance with mandatory regulations related to local administration, such as municipal corporation, government, pollution control board, fire safety department, water supply, and drainage department. The most important consideration while planning the operation theater is the location of the operation theater. So the maximum 6 suites in an OT complex can be accommodated, and they should be preferably on the ground floor. There should be easy access to central sterilization department, emergency department, and surgical wards. The maximum protection from sun, sound, heat, and wind should be there. It should be independent of general traffic flow, and there should be easy access to other areas of the operation theater. Now, standard size of the operation theater will depend upon the requirement of the hospital, whether the surgeon is working in an institute or is a solo practitioner. If he is a solo practitioner, then the standard size of operation theater required will be 20 by 20 by 10. The standard occupancy in this operation theater will be around about 5 to 8 persons at any given point of time inside the OT. The equipment load will be around about 5 to 7 kilowatt considered per operation theater, and ambient temperature and humidity at each location to be considered while designing the system. Now this shows the design of the operation theater where OT1 and OT2 are shown, and each OT is having separate scrub area, transfer area, separate corridor, the rooms for the staff and all. Now this, while the planning of operation theater, we always speak about the zones, 4 zones. The outermost zone is a protective zone where there will be area for the reception where the patient will first will be seen. Then next zone is the clean zone where there will be room for the preoperative room for the patients, recovery room for the patients. Then there will be changing rooms for the male and female surgeons, and there will be storage room for the drugs. Then there is most important area in the operation theater is the sterile zone. There will be operating room. Then there will be area for the scrub room, anesthesia room, instrument sterilization area, and trolley area. And lastly is a disposable zone where after completion of the surgery, all the linen and the surgical instruments, they are kept, and the equipments, the only essential and required equipment should be kept in the operation theater to avoid the overcrowding. As regards the ophthalmic operation theater, we require one operation table. This table should be comfortable for the surgeon and for the assistant. It should be height adjustable and tiltable. There should be adequate space around the operation table for the free movement of the patient and the attendants. Then there should be one surgeon chair. This surgeon chair should always be height adjustable and ergonomically suitable. There should be backrest and the handrest. Then there should be one assistant stool, which should be height adjustable. There should be instrument trolley, boils machine, suction machine, facility for the oxygen supply. Then the emergency drug tray should be made available. Then there should not be any fixed furniture in the operation theater, and there should not be any hanging wires in the OT. Then strict discipline should be observed in the OT. High standard of discipline should be maintained. OT list should be prepared a day prior to the surgery, and it should not be changed. When the patient is received in the OT, he should be checked for the identity. He should be checked for the eye to be operated, the type of surgery to be done, and whether the consent of the patient is taken or not should be checked. The attendant should again see for the sterility of the equipments, whether they are sterilized or not. Unnecessary movement or unnecessary talking during the surgery should be avoided. Any hurried actions during surgery should not be there, and silence should be maintained. The door should be closed during the surgery, and great care should be taken during transfer of the patient after completion of the surgery. The staff should be kept to the minimal during the surgery, and they should know their duties well, and they should be willing to cooperate during the surgery. They should take hand wash before entering to the operation theater, and they should check for the availability, sterility, and functioning of a required instrument before starting the surgery. Coming to the OT protocols, it includes preparation of the patient, preparation of the surgeon, hand washing, gown wearing, gloves, the OT sterilization and airflow pattern, and management of spill and body splashes. Coming to the patient preparation, the patient should be admitted 1 day prior to the surgery, and good bath should be taken by the patient, and outside clothing should be discarded, and clean hospital clothing should be provided to the patient. Similarly, the surgeon should also use the OT dress, cap, mask, eye protection, and footwear. The preparation of the surgical site. The purpose of the preparation of the surgical site is to reduce the resident and the transient microbial count at the surgical site immediately prior to making a surgical incision. To minimize the rebound microbial growth during the intraoperative and postoperative period, and to reduce the risk of post-surgical site infection, as well as to prevent injury to the patient during surgical skin preparation. For skin preparation before the
Not audible, sir.
to be followed by a surgeon. First, we scrub the palm, then between the fingers, then wash the back of the hand, then drill the fingers around, then upside down, and lastly the thumb attack. So this is the way how to take thorough hand wash by the surgeon. Then coming to the gowning, after taking the hand wash, the surgeon should dry the hands, then pick up the gown with one hand, let the gown unfold, and then open the sleeve of the gown and slip arm into the sleeves and hold the arms out and slightly up, and then the assistant will tie the gown. After gowning, the similar steps are there for the gloving. All the aseptic precautions should be taken while wearing the gloves. Then next step is the draping of the patient. The purpose of the draping is to isolate the surgical area from other parts of the body that have not been prepared for surgery. It will also isolate from non-sterile operating room equipment personnel. The principles of sterile technique. All the materials are used as a part of sterile field for an operation must be sterile. The instrument sterilization can be done one night prior to the surgery or just before the surgery. Once the instrument is removed from the sterile wrapper, either it should be used or it should be discarded. The linen used is of dyed green color. All the materials, sterile materials only, and maintain the sterility throughout the procedure. Sterile areas are set up just prior to use. If in doubt, consider the material as non-sterile and hence it should not be used. Only the top surface of the drape table is considered as a sterile area. Neither the scrub nor the circulator should intrude up on the other's area at any time. Sterile person should not touch the unsterile material. The scrub should be considered as a sterile person, and gown, gloves, drapes, and hand position should be observed. For making surgery safe for the patients, all persons entering the sterile area should change in freshly laundered clothing. The clean caps and masks should be used. Boots and shoes must be clean and anti-static. Change the mask during the interval of surgery. Now, there are 4 different sources of infection during any operation, and that is true for the ophthalmic surgery also. The first source of infection can be from the persons, can be from, that is, either entry of the surgeon, patient, attendant, or staff. So this should be avoided by minimum persons 5 to 6 should be allowed in the operation theater. No visitors should be allowed, and use of proper dress code, that is autoclave dress, cap, mask, and proper aseptic precautions should be observed. The second source of infection is the contaminated air. For that, positive pressure ventilation or sterile air from ventilation method should be used, and sterile air flow should be from the operation table to the exit area. Temperature in the operation theater should be kept between 21 to 24 degrees centigrade, and humidity should be always less than 50%. The contaminated instrument is also another source of infection. For that, we have just now listened to the previous speaker that how to take care of the instrument. So use of proper and approved procedures for the sterilization of the equipment is to be observed. And you can use pre-sterilized disposable instruments that will also decrease the risk of infection. And lastly, the contaminated fluids. The constant alertness to the possibility of contamination of the fluids should be kept in mind, and before use, they should be checked. This is the air change in the operation theater, which can help to reduce the risk of infection. Standard precautions that are to be taken, they are hand hygiene, use of PPE kit, antiseptic technique, prevention technique and prevention of the needle stick, environmental cleaning, instrumental reprocessing, and waste management. Important design considerations include operating room storage lounges, dressing room, restroom, showers, sleeping facilities, and administrative offices. One must be prepared to justify the request for spaces and generate budget. So in conclusion, in the present era of evidence-based medicine, it becomes imperative to give maximum importance to planning an operation theater complex. Ideal ophthalmic OT can provide maximum benefit to the maximum number of patients. It can save surgeons from the stress. It can prevent devastating complications like endophthalmitis, and it can improve the cost effectiveness of the hospital. Thank you, sir.
Thank you very much, sir, for explaining in details each and every step and protocol which should be taken into consideration ideally when we are working in an ophthalmic OT. Thank you so much. Now moving on to the last talk of this webinar, may I invite Dr. Uday Gajiwala. He'll be speaking on OT monitoring and surveillance.
Good evening, everybody. Is my screen visible?
Yes, sir.
Okay. At the outset, I would like to thank Dr. Anil Shah and ISMSICS Maharashtra chapter for giving me this opportunity. Friends, monitoring and surveillance are very, very important. I have based my presentation on the cataract quality manual developed by Vision 2020 Right to Sight India program. So what all needs to be monitored? We need to monitor the OR environmental sterility, be it the air, the surfaces, the water. We need to monitor the sterilization procedure and effectiveness of sterilization, whatever method of sterilization that we use. We need to monitor the surgical supplies, particularly the pre-sterile material that we purchase from the market and use it. Then if any surgical infection or inflammations occur, we must do the surveillance. There should be, if it's a bigger hospital, an infection control committee should be in place, which can review the outbreaks of infection and revisit the protocols. And there's a need for continuous training of personnel. So let us look at what all we need to do with the environment and surfaces. Having done the disinfection of the environment and surfaces, we need to monitor it by microbiological methods. We can either do passive monitoring by doing air sampling using open dish sedimentation technique, or we can do active sampling using a bacterial counter, the gun that is shown in the picture below. We need to take swabs for culture from sterile and unsterile areas at regular intervals, depends on the load of the particular hospital. We need to take nasal and nail bed swabs of the personnel working inside the theater. We need to use various checklists. These are daily, weekly, monthly, quarterly, etc. And we need to use checklists of various tasks which are scheduled to take place inside the operation theater. Even WHO has talked about surgical safety checklists. Dr. Atul Gawande, who was the chief who developed these surgical safety checklists, he was heading the team which developed these surgical safety checklists. And he moved around in different arenas and realized that checklists are used in all different fields, not just medical, even outside medical field. And he wrote a fantastic book titled The Checklist Manifesto. I recommend everyone to read this book. Surgical safety checklist developed at WHO talks about 3 different checklists. One just before induction of anesthesia. In our case, it could be between the patient being sent inside the operation theater, the ward nurse and the theater nurse. They need to do the sign-in procedure. Then just before the incision is made, a timeout procedure needs to be followed. And just before the patient is sent out of the theater, a sign-out procedure needs to be followed. So what are the different checklists that need to be used? There's one preoperative checklist, and then, as I said, daily, weekly, monthly, quarterly checklists. Then something little non-clinical, but emergency medicine checklist. At times, some medicine has been used from the tray, and right at the time when we need it, it's not available in the tray. So that also needs to be checked at regular interval. Then OT preparation. Depending on the number of surgeries for the next day, how we will prepare the equipments and instruments and linen and everything, and that also has to be done using a checklist. There are a few non-clinical checklists that we need to use. So who all will be available inside the OT, who will be doing what task, who will prepare the OT, daily OT report is to be given. These will be helpful when things have gone wrong and we are trying to investigate what has gone wrong in the theater and where things have gone wrong. There are several tasks that take place inside the theater on Sundays, and that also is monitored using checklist. There's a medicine usage that occurs in the theater. There's a medicine checklist, and there's a turnover among the theater assistants in the operation theater at our place, and so we use a monthly handover checklist for the assistants. Then there are several reports that we have to use. So there is a logbook of autoclave cycle that we maintain. There's an autoclave SWIFT register. Dr. Purvasha also alluded to the same. Then if you're using an ETO sterilizer, ETO register, SWIFT register is maintained. Report of biological indicator that we use has to be maintained. Culture report of the theater, which I mentioned, including the culture of the environment, has to be maintained. Then register for usage of irrigating fluid and viscoelastic, which should include the batch number and the expiry date of the material that is used. Then there is an OT cleaning register, there's a fumigation register. Friends, we keep an overhead tank cleaning register. I have audited several hospitals across the country, and I've seen that people forget about cleaning of the overhead tank, and many times that is the source of contaminated water being supplied to the operation theater. And then there is a report of consumables that is utilized inside the operation theater. Here I'm showing you the preoperative checklist. I would like to draw your attention to the bottom of the same. The ward nurse also signs the same. The theater nurse will also put her signature. So there is no ambiguity in making sure. And there are several checkpoints that are available for us to make sure that we have not missed anything. I have seen wrong IOL being implanted, wrong eye being operated, etc., in different places. This is the logbook of autoclave cycle. This is the one we use for class B, the horizontal autoclave with vacuum cycle. When we turn on the heater, when the pre-vacuum is done, when the steam pressure is attained, how much time was taken for sterilization, when the steam was released, all this is recorded, and it is signed by the person who runs the autoclave cycle and the theater in charge also. Friends, Dr. Purvasha also showed us the autoclave SWIFT register. I just want to draw your attention to the right side 2 columns. The theater in charge has put a signature and the operating surgeon has put a signature. This is done just before the surgical activities start inside the theater. And note that all the drums that are autoclaved are marked what item was sterilized in that drum, and what was the date of sterilization is also mentioned here. All these details will help in retrospectively trying to understand where things probably have gone wrong. Fast cycle, Dr. Purvasha also mentioned. Here also we must use a sterility indicator. Ethylene oxide gas sterilization indicator is a different color that is used for ETO sterilization. Then the biological indicator, if we use it, is sent for culture after the cycle is completed, and there should not be any growth or turbidity after 72 hours. And that is definitely telling us that sterilization had occurred for sure. This is the report of environmental culture, the air sample, and there also we should not get more colonies grown. The limit is 30 colonies or 180 bacterial carrying particles in 1 agar plate. Report of culture of sterile and unsterile area swabs. The unsterile area swabs can show some growth. The interpretation of the result is very important because we have not sterilized the unsterile surfaces like the floor or the wall or the operating table. There can be some growth. There should not be a growth of a gram-negative organism or any fungus, that will indicate very bad cleaning activity being done inside the theater. And that's the importance of unsterile area swabs. Naturally, the sterile area swabs should not have any growth. Record of use of irrigating fluid and viscoelastic with the expiry date and the batch number, etc. This will help in retrospective analysis. And a record register of various tasks performed in the theater by different people. This will have their name and signature, so we can cross-check when things go wrong. This is a daily cleaning checklist, and again, look at the bottom. It has to be signed by the people who do the activity and must be signed by the theater head. This is weekly cleaning. Daily, we have to do a lot of activities. Weekly activities will be a little different. Monthly, naturally, there will be fewer activities, and quarterly, there will be very few activities. However, there are a few things which must be done at quarterly interval to make sure that the functioning of different equipments is appropriate. This is the preparation for operation. So the top tells us about the activities done on that particular day, and the bottom, how much of linen, etc., instruments and irrigating fluid, viscoelastics, etc., were autoclaved. How much material has been put in one drum is also to be ensured, because Dr. Purvasha also showed us tight packing is not a good idea, and in that case, steam penetration will not occur properly. So we have to do a loose packing, and that's where how many items are sterilized in one particular drum is important, and that needs to be monitored. Then Then there's a checklist of the emergency tray. So as I said, sometimes the material was used and not replaced, and we may fumble when we need it in critical moments. Friends, why we need to do a quality assurance? Because sterilization, which is dependent on machine and human being, both can end up with an error. Lot of activities are done in the absence of the doctor. These are done by our staff members who may not be aware of the science. And then how we will monitor these activities is very, very important. Many times my junior colleagues, when I ask them to sign the autoclave strips register, they tell me, I did not observe the sterilization running of the autoclave machine. Why should I put my signature? Then I tell them, you are putting a signature saying that you have cross-checked the color of the indicator tape and it is jet black in color. That is what you are certifying. So we have to understand why each and every activity is being done. So as far as monitoring the sterilization procedure is concerned, we can monitor by mechanical indication, we can use chemical indicator, we can use biological. As I told you, autoclave cycle logbook needs to be maintained. Then chemical indicator, Dr. Purvasha alluded to 6 different classes of indicators. Chemical indicator is class 1. It works by change of color, but this change of color depends only on one parameter, temperature. So if the color of the indicator tape, the chemical indicator is black, jet black, that means that the temperature was attained. It does not indicate sterilization. So we can use, I'm not going into the classification. Instead, I am saying process indicator. So vapor line indicator or a Bovidic test pack will indicate that the process was done completely, which is better than using only the chemical indicator. But as I mentioned previously, the biological indicator is the method which will tell us whether sterilization has occurred properly or not. And there are different types of biological indicators available. So Bacillus stereothermophilus spores are used for steam and dry heat sterilization, and Bacillus subtilis spores are used for monitoring ethylene oxide sterilization. And these are the indicator ampules in the picture. Monitoring the sterile supplies, particularly the pre-sterile material procured from the market. We must check the expiry date. We must check the sterility indicator. At times, the indicator may not be properly indicating sterilization process. The color may not be appropriately changed. And we should check the pack also for its integrity. It should not be broken, should not have holes. This thing has also happened. And having trained the OT boys, they did find out hole in double packing of viscoelastic from a very reputed company in our place, and we survived a major mishap. So it is very important to check the integrity of the pack. That was all about the monitoring. Coming to the operation room surveillance, surveillance must be carried out according to a predetermined protocol. Interpretation of results and action to be taken are very, very critical. And 5 important criteria are to be remembered. Surveillance must be planned, purposeful, scientifically accurate, should be properly documented, properly analyzed, effectively communicated, and if required, a modification of the protocol being implemented. That's the surveillance done meaningfully. So friends, trying to do the surveillance, we have to do surveillance of our own preoperative practices. If this is not monitored, our own staff members may become complacent and the practices may change without the ophthalmologist realizing that the practices have changed. So all the preoperative practices, intraoperative practices, and the post-operative practices must be monitored at regular intervals. This should be done as a surprise check occasionally, once in a while, but that may tell us if the practices are changing. We have to monitor the cleaning and sterilization also. Proper washing and drying of instruments, as mentioned by Dr. Purvasha, are also very, very critical. And data of purchase and proper functioning, all the equipments must be ensured. Microbiological surveillance by taking culture from sterile and unsterile items is very important. However, the significance of the organisms is important, as I mentioned previously. So before I end, I just want to highlight this. Dr. Khere also mentioned this, but I want to highlight it a little differently. He mentioned about the 4 things. Of the 4, sterilization failure will result in a cluster, and that is of paramount importance for us. And so to monitor the sterilization procedure being done, whether inside the hospital or we are using pre-sterile material, is very, very, very important and critical. If we fail in practicing no-touch technique, then there will be sporadic cases of endophthalmitis. Environment comes last. Of course, patient factors are also important, and that is the importance of our preoperative workup. So we must monitor all these 4 factors, and I have mentioned all the details how we need to do it. Thank you so much. Thank you.
Thank you, sir. It was a very excellent presentation and with a lot of take-home messages. Now that all the speakers have presented, the topics are open for discussion. But before we ask any questions or add to the inputs, I have got a basic question for all the speakers. Like as regards sterilization, OT protocol, or quality control, what difference is usually followed or can be followed in case of a private setup where there is low volume surgery, and in case of an institute where there is very high volume? So any of the speakers can take the question.
What kind of differences you mean here?
So in process of sterilization, usually there is no difference, but as far as following the protocols and the quality control, if very high volume surgery is there are certain protocols which are to be followed more meticulously. That's what I meant to ask.
I don't think there should be any difference in the protocol, whether it is a small practice or a high volume practice. The difference could be in weekly cleaning of the operation theater. The cleaning of the environment can be done less frequently, something like that. But I don't see any other difference in the protocol.
Like
That's my
taking the OT swab and all.
Yeah,
That
that can be done at a longer interval if it is a small practice.
May I add one thing here?
Sir,
Yes,
I
sir.
think in bigger setup there are so many people available for various steps to be taken, various steps to be followed. Whereas in smaller setup, the number of people are little less. So the responsibility which is given to various people in bigger institute cannot be given in smaller setup, and less number of people have to take care about this. Maybe surgeon, few of the assistant, and some of the OT personnel, and they have to look after. But no step should be skipped. That's very important.
I would also like to add this thing, the volume is low, so we might not require all the steps which is required for a high volume to be followed here. That is one more take home message. Let the faculty also speak on this.
Footfall is also more. In
Yeah, I
case of
think Dr.
institute, footfall is
Anik
also
also
more.
Yes.
Hello.
Dr. Anik wants to make a comment, I think.
Yeah.
Yeah, I think this thing network is not
I think
proper.
network is not.
Yeah.
So I think Dr. Khaire or anybody
Yeah,
can take
thank
Yes,
yeah.
I would like to
Dr.
add,
Anik.
if you are a solo
to
practitioner.
congratulate.
Hello.
Oh, she's speaking.
Hello.
Okay.
Yeah, Dr. Anik.
Yeah.
Hello, Dr.
Yes.
Anik.
Yes. Hi. I would like just to congratulate all the speakers. Yeah, excellent presentation. I have some comment for Dr. Purvasha. I just come from Montreal, Quebec, where I was in the COS, the Canadian Ophthalmology Society, and they congratulate the Aravind Hospital because they have a less amount of endophthalmic.
I think your voice is not there.
All things.
Your voice is breaking, Dr. Anik.
Yeah. It's yeah. You hear me?
Yes, we can hear you right now.
Hello.
Yeah.
So in case of solo practitioner and small OT, so we have to always depend upon the sterilization on the fogging. But if you are a large institute and you have facility of air handling units, then probably that is more safer. That is one thing. Secondly, in big institute, in between the surgeries, you can again go for cleaning. That can help, which is not required in a smaller setup.
Dr. Purvasha, do you want to comment on this?
Hello.
She's joined back. You wanted to
Hello.
come.
Hello. I lost I lost the connection. I'm sorry. I think it will work better without the camera. Let me
Yeah, you
try
can do
again.
without the video, so
Yeah.
your network will be better.
Yeah. What I was said is then I was last week in Quebec, Canada, and there is a conference where they congratulate Aravind Hospital because they have less endophthalmitis than it was in United States and Canada. And I can say after this conference, I can understand why it's like that, because of all that we take care about, the sterilization, cleaning, and all other things. But the things that I have to add is just about someone asked the question about disposable material. Yeah, it's very good disposable material, but it's expensive. And now all the things is about environment, how to do to reduce the amount of the waste that we have in the OT. That's the thing that we have to think about, the environment and the health where we live. That's all my comments for now.
Yeah,
That's a
Dr.
very
Annie, that
precious comment, Dr. Annie. And yes, carbon footprints of your cataract surgery have been a source of concern, and Arvind has excelled in that also by reusing many things, and then it has also still managed to do high volumes and still achieve the best, the lowest endophthalmitis rate. So I think it's really commendable, and there's a lot to learn from that setup. And even the West is now looking towards systems where they can reduce their number of disposable items and reuse most of the things, which is actually a waste of resources, adding to the burden of the biomedical wastage and all these environment burdens. So I think there's a lot to still work up on.
So at Arvind, are they using disposables or linen ones? If they're using disposables, how do they manage that?
They are using cotton gowns, and everybody, like how in the West they suggest that everybody scrubs for each case and all that. So this here they say that each surgeon sits for 3 to 4 hours, and they continue to wear the same gown. And if it's more than 10 or 14 surgeries, something like that, then they change their gowns. Scrub nurses are, and the surgeons are also not changing their gloves also, so they're just using the chemicals, and they are using that to clean their gloves and then continue with that. They are utilizing the disposable syringes also. They remove the pistons from the syringes and then they send for autoclaving. They one thing that they don't compromise on is the ringer lactate bottles, which they say have not been actually sterilized or have been intended for ophthalmic surgery use. So they autoclave it 1 day prior and then they store it for the next day's cases. So some real good innovations and protocols being followed there, which are, something to learn from.
What
do they
about
use
gloves?
autoclave,
Gloves,
glass bottles for autoclaving?
obviously.
Because plastic won't be used
No,
at all, na? In Arvind.
no, sir.
Quite right. Okay.
Can I make a comment?
Yes, sir.
Please, sir.
While we are talking about practices at Arvind, let us remember that All India Society guideline on prevention of infection talks about change of gowns after 5 surgeries and change of gloves after each surgery. However, the AOS guideline will not be the final verdict. It will not be valid in legal matters. And so legally valid guideline is the one from National Program for Control of Blindness. We could not come to a consensus about change of gowns, etc. So the NPCB guideline is quiet on that issue. However, change of gloves after each surgery is mentioned even in the national program guideline. Thank you.
So after scrubbing, change of gloves.
Yes, sir. After each surgery.
In one of setup, what I witnessed, they used to wear 2 gloves. So remove outer one and wear on that.
That is not required actually, sir.
Because they don't scrub in after every case. They scrub once, put 2 gloves, 1 gloves removed and replaced with another one after each surgery.
But then what is the point in having a second pair? If you are going to change gloves after each surgery, the second pair serves
just safety, security, whatever we may say.
No, sir, it doesn't.
And one thing I'd like to mention about autoclaving of these glass bottles, in one of literature, my thesis was in IV glycerin. So in one of literature, I came across that during autoclaving of these glass bottles, some micro glass particles may give troubles to you. I don't know. So that's why I totally stopped and using normal ringer lactate and with plastic bottles and all the way happy with that.
Autoclaving of
glass bottles. Yes.
Irrigating.
Because we prepared glycerine and then IV glycerine we have used at that time. So since then, I have never used these glass bottles. I don't know. People are using.
Sir, it's a very
Even people are sterilizing viscose also. I don't know what practice at Arvind House.
Sir, but this is a very controversial subject.
Yeah, exactly.
And the only thing I would like to add here is I had a discussion with the head of pharmacology at AIIMS Delhi, and he said at least the chemical composition of ringer lactate will not change if you autoclave it.
Okay.
But yes, I agree with you about leakage of the glass particle or the breakage of small pieces of the rubber cork, etc. A lot of debate is there on this topic.
Yes, exactly. But we have to think what is ideal and what is practical. We have to demarcate.
We have to use something which we can trust. At the end of the day, operating surgeon will be held responsible for anything going wrong.
Exactly.
Nobody else. It is our neck under the sword. So we have to be very careful in selecting what we want to use. We use pre-sterile material purchased from the market. Believe me, sir, clusters, most of these clusters have occurred because of the irrigating fluid.
Yes, almost always visco and irrigating fluid. These two are major culprits.
Right, sir. And I have seen people use local brands of irrigating fluid. We must use very reputed brand, something which we can trust. That is what I would like to.
And physical verification is must before putting each and every bottle.
Correct. Sir.
Yes, that is very important.
And sir, what is the expiry date of autoclaved surgical instruments? Autoclaved. Sir, generally, we are doing autoclaving on the day of surgery or day before. And if suppose our list is postponed or cancelled, can we use it on third day, fourth day, whatever it may be, or we have to re-sterilize this?
Sir, if it is sterilized in a rigid stainless steel drum, the validity is maximum 72 hours, provided you have not opened the drum. If you open the lid of the drum even once and don't take out anything, even then it should be sent back for sterilization. So if it is a rigid container, 72 hours. If it is double pack linen, it is 28 days. And if it is ET or sterilized, it is 1 year.
That's nice. So most of the private practitioners or solo practitioners are using this autoclave. So I think 72 hours is the total duration.
Dr. Gajiwala, one question is regarding the batches of the RL that you're using, the plastic bottles. You also use plastic ones or you use the glass ones?
Glass bottles.
You use the glass bottles, okay. Yes, so you do autoclave them or you also directly use it?
Sir, we autoclave them.
And that is 24 hours prior or you have a timeline for that too?
24 hours prior.
Okay, and regarding, you're not using this thing, so can I ask Dr. Narang, if she is doing this thing, plastic bottles, RL, and are they taking the whole sample or do you send it for microbiological examination of at least one bottle, if there is anything wrong?
So
anybody does it?
No, sir, we don't, because patients get it from different sources. It's not in a batch that it's coming to us. So they buy it from outside and there are a variety of things. So we can't keep a track of so many batches of different companies coming to us. So that's one big hindrance in the tracking back in
just
case
a physical watch and use it.
Just a physical watch.
We are using rubber bottles, plastic bottles, but from reputed company. At present, I am using Kabi. And it's reasonably good. Before even Nirma, we have used only reputed company plus physical verification. These two things we are missing.
Sending one bottle from each batch for sterilization testing is useless.
Useless.
I can take 5 minutes to explain why. At the point of manufacturing, in today's circumstances, it is sterile. Let us not doubt that part.
Yeah.
Nowadays, manufacturing is totally without any human touch.
Yes. Form filled and sealed.
So it will be sterile at the point of manufacturing. But things go wrong after manufacturing when it is stored in the warehouse of the company, going to the super stockist, to the retailer, to the patient, and coming to us. There are several hand changes. One. The other is during storage to transportation, there is handling by labor class people.
Right, right.
And they throw the packs literally. And we don't know which pack was thrown at what speed. Or when the packs are stacked on top of each other, even if it is a plastic bottle or a glass bottle, when we stack more than 7 cartons on top of each other, the lowest one develops microcrack. We don't know which one was on the bottom. We don't know which bottle has developed microcrack. So sending one bottle for testing will just give a placebo effect that this batch was sterile.
Yeah, it could be a false negative
This
also.
bottle was having microcrack, and that is why the suggestion is to use one bottle for one patient.
Absolutely.
Then it is only one patient at risk.
One more question is regarding the HIV patients, the instrument. What is your protocol? What Dr. Narang said was very nice. Do you have anything different to share with us?
Sir, we don't do double autoclaving. We put them in chemical for half an hour, and then
Which chemicals
autoclave
do
it
you
once.
use?
Pardon?
Which chemicals do you use? Acrylamide only?
Sidex, I think we are using Sidex. But half an hour of immersion in chemical, then cleaning and single autoclaving. Sir, all these viruses are very, very heat labile viruses. They get killed at 57 degrees centigrade temperature. We are autoclaving at 121 degree temperature. So single cycle is definitely enough.
What about tubings, Peco tubings for HIV patients? Are they discarded or reusable? What do you do?
Preferable to use, if we know that the patient is HIV positive, preferably disposable.
We are doing SICS in all such type of cases, not using Peco tubes.
नहीं sir, पूछ रहे हैं भी साथ में भी this part of it. Anyway,
That is also,
can I ask one question?
That is also
What is
another aspect.
what is everybody's take on using BSS, BSS plus and RL as a irrigating solution?
very good question.
RL.
RL.
Yeah, I also use RL.
RL.
So the
Agree
AI
with it.
survey told us that more than 60% of our own colleagues are still using RL. More than 60%. Sir, it is an off-label use and we should not be afraid of off-label use. There are a lot of drugs that we are using off-label.
Yes.
We don't even realize we are using subconjunctival injection of different drugs. None of these are meant for subconjunctival injection. It's off-label use.
Moxie drops as intracameral.
Intracameral use.
But again, if doctor is satisfied and main burden is on that, and if he is satisfied, then he can use.
Regarding Kinocort, Gadiola sir.
Yes, sir.
What do you do? Kinocort, it is a direct use you do, you dilute it and use it and dispose it off, or reuse it. In case there is a vitreous loss and you want to see, there is this thing in the anterior chamber. The Kinocort that you use, how is it? Is it
diluted?
Diluted 1:1?
Yes, sir.
Okay. Fine. And then you throw it off because there's a lot of Kinocort in one. So
after single use, we throw it off. We do not reuse anything.
that's very important.
Sir, for one question is that for cleaning distilled water is used. Can we use RO water for cleaning the instruments?
Definitely we can use.
But it leads to more corrosion of the instruments. So better to have distilled water. After cleaning, it's better to dip it in distilled water.
Sir, RO water also has a little bit of salts. When you do the TDS count, it will be somewhere in the range of 100 to 150.
Yes, exactly.
Then the taste will be comfortable. We cannot bring it down to 0, whereas in distilled water, the salts are 0. So it is better to use distilled water.
Distilled water.
There are two types of distilled water which is available. One is the medical grade distilled water, sir. And the other one is the regular use, they use for the injections and all. So I think they have to use medical grade distilled water. Because I had used once, the different ones, definitely there is a problem, because that is the go home message which should go, should be a medical grade distilled water should be used.
Can we use the distilled water which is used for inverter batteries and all this? 5-liter distilled water package there.
Not at all.
For cleaning
That's
of
what I said.
instruments,
Medical grade distilled water is available. You can't use the regular one.
Not used. You cannot use.
For cleaning purpose, we can.
For cleaning only. For cleaning the
Yeah, yeah.
instruments.
For cleaning, we can use.
Normally, sir, after cleaning one instrument set, what I do is that I put all the instruments, one instrument set in the oven, hot air oven, like cake oven is there. In that cake oven, I keep the instrument for 5 minutes, and it is a mini sterilization there. And after that, I remove and then put it for sterilization.
It is after washing.
After washing, drying, when the set is ready, I put it in the cake oven. Cake
Okay,
oven
okay.
is there. In
Yes,
that
Like a
yes,
hot air oven, correct?
hot air oven, in that I put it and keep it for 5 minutes at a dry heat. Means that gives us dryness of instrument and also mini sterilization of the instruments. This is for solo practitioners.
This is for all instruments, even also the Simcoe cannula and all.
Everything, all complete set is kept in the dried sterilization. Means in
what temperature, sir?
Hmm?
At what temperature?
That's what I was going to ask. What temperature and how
The
much
temperature
time?
is more than 120, sir. For 5 minutes.
Tubings will lose.
Tubings will affect it.
Yeah.
Not as I've kept silicone tube and all Simcoe cannulas, they are not affected, sir.
But sir, at the same token, please do not consider that as semi-sterilization.
No. It is just for the drying and sterilization. After that, we keep it for regular autoclave.
It's only good for drying.
Drying, all the waters and everything is removed, and the instrument become dry, and it is little heated also. So whatever the moisture that is everything is removed.
Anil Bhai must be doing mainly for the Simcoe cannulas to dry it up inside the lumen also.
Yes,
that could be one of the reasons for the hot air oven use.
Yes, inside the tubing also should get dry.
Dr. Purvasha,
Yes, sir.
the ultrasonic cleaning should be before washing or after washing?
So there should be washing after cleaning, because
After ultrasonic cleaning.
after cleaning. So we are
Okay.
rinsing it first, we're flushing it once, and then we are putting it in ultrasound cleaner so that whatever micro vibrations are happening, they release the organic material from there. And then whatever is released, if it's loose inside the lumen or inside the crevices and hinges or whatever, then that has to be flushed again or rinsed again.
Nice.
Dr. Purvasha, as you were saying that as soon as the surgery is over, we have to first clean all the crevices and all. But while doing so, our staff may damage the tips. So is there any alternative for this?
Pardon?
Our staff may damage the tips.
Yes.
Which are very delicate. So instead of washing them and then keeping in the ultrasound, and we just keep in the ultrasonic machine so that all the material loosens up, and then we can wash it again.
So the basic idea of cleaning is basically to remove the bigger chunks of material, the macro cleaning, and ultrasound does the micro cleaning. So the bigger chunks won't come out in ultrasound cleaning. So you have to manually clean them first and remove the debris or the solidified material, and then only it will work as the ultrasound will be able to take care of the finer stuff. In fact, cleaning of the ultrasound chamber also has to take place daily. So that is again a protocol that to be followed.
And regarding sterilization,
Yes.
do you prefer autoclaving or ETO? Like, what are the pros and cons?
Autoclaving is the gold standard, so that cannot be done away with, and it's not one against the other. There are only certain very few instruments which go for ETO from our place, like vitrectomy cutters, which are disposable or we want to reuse them. But otherwise, autoclave is the gold standard for all instruments. Only ones which are heat labile will go for ETO.
Gajiwala sir, very important question is regarding the AC. what is the protocol each person is following for mainly for solo practitioners who don't have, otherwise you have an AHU in all the big hospitals and this. What about the solo practitioners about recommendation of air conditioners? Split windows are of course out and maintenance of that. How frequently it should be done?
Every week.
And then-
Maintenance must be done every week. Split air conditioner, off the record, I'll agree with it for solo practice. NABH will never.
Absolutely.
Is okay. We should be able to maintain the bacterial count low inside the air. Basically, that is the purpose of AHU. As I said, less than 180 bacterial carrying particles per cubic centimeter area. That is the requirement. Or in other words, minimum 20 air changes per hour. Split AC cannot give us 20 air changes in 1 hour. That is one limitation. We can put air cleaners inside. We can retrofit laminar flow. However, laminar flow is also objected to in NABH, the retrograde fitted laminar flow system. But that can create a sterile area on top of the head of the patient. So these are some of the gadgets that can be used for solo practice.
What about UV purifiers, sir? They supply UV purifier machines. How long it should be used, and the UV tube lights also in the OT. The
UV
function and how do you use it, how long it should be used, how frequently it should be used, before, after, and during OT.
UV air purifier and UV lights are two different things.
Yes.
UV air purifier, as long as the theater is running, it will continuously keep cleaning the room air. It will suck in air from one side, pass it through a filter and UV light, clean it and send it back to the room. So it should be run as long as the theater is running. Whereas UV lights, the UV light itself is harmful to the human beings. So UV lights are, if at all, used to be turned on after the last person has left the OT, and overnight it can be kept on. Should be turned off before the first person enters the theater.
How many UV lights are required, tube lights are required, and what is the space? 10 by 10 OT, 20 by 20 OT, how many UV lights are required? Tube lights.
3-foot size UV light will hold good for 1000 cubic feet area.
Right.
But the UV light also has its own life. So you ask the manufacturer how many hours is the life of that particular UV tube, and after those many hours we should change the tube.
Okay. Because it's burning but it's not effective, so we should change it. Quite right, sir. Narang madam, your views on this?
So we have guidelines for eye banks for use of UV lights. So that is where we have actually used it, where the tissue processing is taking place, where the corneal buttons are being made from the nucleated eyes. Only there they recommend for before, and like sir mentioned, there should be no human presence while the UV light is on, and then only it's carcinogenic and it's mutagenic, so it's not safe for use when people are around. So that is where we have used it, not for the regular OT area.
And what about the UV air purifying machines? Do you use it? Do you recommend for the solo practitioners?
So I have no clue about that. We have not
Because what happens, I'll tell you,
procured
air
any.
handling units in a solo practitioner, very few have it. In the rural part of Maharashtra, wherever we are, I mean, it's very less. So they depend mainly on either split AC with the air purifier units. So how much it is correct legally also, and if there is a problem, what exactly, how to manage it. That's why I asked this question. Because majority use this, all of them don't have the air handling units, I'm sure.
Dr. Anik, madam wants some question.
Yeah.
Yes, thank you. Yeah, I have a question for Dr.
Again, her voice is gone, I think. Network problem, I think she has.
Right. Ute sir, I wanted to ask you something.
Yes, madam.
So if where in cases where there are multiple subspecialties running in the OT, and suppose you have a case of cataract and then you have to take up surface cases or some other case, what do you recommend, sir? What should be the protocols in between, or is it recommended, or should we have a separate OT for that?
Preferable will be to have separate OT. If that is not possible, finish all the cataracts first and then take plastic cases.
Intraocular first.
Intraocular first.
Sir, any role of steel OT, HEPA filter, dehumidifier? What is your opinion, sir, about the latest steel OTs and all these things are there?
Steel or modular OT
Modular OTs, yes.
is not indicated for eye surgeries. It's not required.
Yes.
So absolutely clear on that.
Okay.
Dehumidifier, if you have AHU, air handling unit, you don't need dehumidifier. But as Dr. Tasala sir was saying, for solo practice, it may not be feasible to go for AHU. And if we have a split AC, we should use air cleaning system. Similarly, during monsoon, if the humidity is going very high, we should use dehumidifier. Actually, our air conditioners are also kind of dehumidifiers only. But still a dehumidifier, say for example, we are near the sea. Humidity goes up to more than 90% in monsoon. Now the humidity needs to be maintained between 30 to 60. If it is above 60, the organism's growth is very fast, very rapid.
Tremendous,
yes. And so if we can keep the humidity below 60, the growth of the organisms will be slowed. And that is the reason why we should use dehumidifiers. Sir, when we started putting a dehumidifier in the OT during monsoon months, at the end of the day, if we had run the OT for 8 hours, you would get more than 500 ml of water, at times 750 ml water. And that much water comes from the environment.
Tremendous. Mainly fungus and all we can definitely avoid. If it is a humid environment, you have, of course, bacterial plus fungus also. So it's a plus point to have it in the OT, especially if you don't have an AHU.
Correct.
Quite right. Very right.
There's one question from Dr. Neeta Sharma. Is it must for surgeon to sign an autoclave strip along with the OT nurse? And does
Yeah, I read that question. Whether you want to call it a must or not, at the end of the day, it is the responsibility of the
responsibility always.
Only. Whether the OT nurse has put a signature or not, it is the responsibility. Nobody is going to call the nurse in the courtroom and ask any question.
Correct.
It will be the surgeon who will be asked the question. So whether you sign it or not, it is your responsibility. Having signed does not mean it gives you any immunity. However, you can argue in the court that I was careful enough to make sure that the activities were done properly. And
like the written consent.
Correct.
Any role of OT fumigation in these days, sir?
Yeah, that's what I was going to ask.
If we have AHU, if we have a positive pressure ventilation, there is no need for any fumigation. Only a deep cleaning is enough. Even if we do not have AHU, if we do a proper deep cleaning, it is enough. Let us understand why. When we start the day, Monday morning, you have done fumigation on Saturday, you start working on Monday morning. The bacterial count is very low. Agreed. The moment you start working, patient is exhaling, staff are exhaling, we are all exhaling organisms in the environment. The bacterial count has started already going up. The last surgery when you're doing, the count will be much higher than when you started OT in the morning. So fumigation is only to keep the environmental count low when you start the theater. It may not be required if you do a proper deep cleaning, and you have systems to continuously clean the room air, whether you have AHU, whether you have air purifiers, whether you have laminar flows. So if you are doing that, a deep cleaning is enough, no need for regular fumigation. But this is very, very tricky. Proper deep cleaning is not understood by most of us.
Definitely.
And having said that, I am doing deep cleaning, I don't need to do fumigation, will put us in a very precarious position. So for the moment, if we do not have AHU and positive pressure ventilation, we should continue with fumigation. But somebody has asked a question whether formalin can still be used or not.
Yes.
I would put my degree on count. It can still be used. Let any of you tell me, have you ever come across one individual who has developed carcinoma because of usage of formalin? No.
No.
Second, the amount of exposure in healthcare situation, in hospital settings to formalin is not as high as 5 ppm per etc. etc. And it is non-carcinogenic. That much exposure occurs in pharma industry.
Correct.
But the flip side of the coin, we don't know actually how much formalin needs to be used for one fumigation cycle. So what most of us are using is much less than the required quantity. So it is just an eye wash in most of our cases.
Right.
So if we use enough quantity, then the cost is not very high if you compare it with any other non-aldehyde product. Formalin is very irritant. And at times it is difficult to enter the OT in the morning. So if you can use non-aldehyde product, it is definitely better. But if somebody is still using formalin, don't worry. None of you or your staff will develop cancer.
Which are the non-aldehyde products do you recommend for fogging?
Sir, there are many products available, but I am very fond of hydrogen peroxide. That is, I am making a mention. Otherwise, there are a lot of other non-aldehyde products available in the market. Why I am fond of hydrogen peroxide is because you can stand inside the OT even when you are spraying hydrogen peroxide. And the OT will be ready in only 1 hour.
What about the corrosiveness of H2O2, sir?
Any
Hydrogen
chemical
peroxide?
is corrosive.
Right.
Aldehyde or non-aldehyde, everything is corrosive.
How we can use hydrogen peroxide?
Hydrogen peroxide with 1% silver nitrate is readily available in the market. And we can spray the same just as we spray formalin. Fogger will be better because it will create much smaller droplets. And so the spread in the room air will be much better if you use a fogger. But we can use aerosol sprayer also. It is fine.
How much time do you do it, sir? 5
1 hour.
minutes, 10 minutes, 1 hour. And open the OT immediately after that, or
after 1 hour. If we are using hydrogen peroxide silver nitrate combination, 1 hour. Keep the OT closed for 1 hour and then you can use it.
What I meant was, sir, fogging part is how much? How much time? Is it that is also 1 hour?
No, so you spray the solution for 1 hour, keep the theater closed for 1 more hour, and then you can use it.
Okay.
But manufacturers will give you their own guidelines. So you can follow the guideline given by the manufacturer.
So the latest plasma sterilization for instruments again is taking the benefit of using hydrogen peroxide. But then people have raised their concerns regarding alloys being used because then this hydrogen peroxide is causing denaturation of these alloys and they are breaking down into zinc and copper and all these things. So I think till date, ophthalmic instruments have not yet been very amenable to plasma sterilization as such.
At the same time, it is very costly also.
Costly also.
Very, very costly.
One more thing is that who takes the responsibility of infection? The consultant, like the surgeon, or the hospital head, institute head?
Consultant.
Legally. or they share the equal responsibility. Institutional head and the ophthalmic surgeon.
Vicarious liability.
That it is the surgeon. not the institutional head.
Every time it is the surgeon.
Institution can give protection in terms of paying for the insurance, or if we lose the case, the institute can pay for it, but the surgeon will be the responsible person. However, there is something called law of vicarious liability.
Vicarious liability, yeah, that's what I said. Very much there.
Kajewala sir, can I ask you one question?
Yes,
What
ma'am.
is your take on surface cleaning in between cases?
If you can practice that, it will be very good.
Yeah, especially in high volume.
There are high volume centers, only a few of them, but they are there in India who do surface cleaning between two surgeries. They are high volume centers.
And which is the best chemical which you use, which you suggest?
All these chemicals are equally effective. The way
Carbolization.
Carbolization is not required, it is acid. Why do you want to use acidic material? The acidic fumes are harmful actually to the human being. So carbolization is not indicated at all. It should not be done.
Bacillocid.
Bacillocid is again glutaraldehyde. Glutaraldehyde, I think glutaraldehyde formaldehyde combination.
Okay. Thank you.
See, we see a lot of advertisements of different soaps. All the soaps are equally effective, but each soap will claim mine is the best. Same goes here for all the chemicals that we use.
True, sir. True.
Best quaternary ammonium compounds which work best, in fact. What is your take on that, sir?
Quaternary ammonium compounds are good. We can use them.
Very good. Yeah. Anything, the way you said soaps, we have this under this heading. This thing should do as a surface disinfectant and otherwise.
Correct, sir.
Fine. Rujuta?
Yeah, so now because of
we have
want of
one or
time,
two questions
I think
in the chat box.
because it will go on and on, maybe till 1 o'clock also.
Yes.
So I thank all the participants, all the speakers, especially for their lucid and wonderful, excellent presentation, and lot of take-home messages given by the chairpersons, discussants, and thanks to our audiences. And I thank NTOT for giving technical assistance. Thank you so much.
One announcement
And
I have to make. If
yes,
half a minute.
Yes, very
Day
much.
after tomorrow, on 30th of this June, Cornea Society of India invited me as a guest speaker on personal finance, basics on personal finance. So I'll send linked in this group. If someone is interested, please do join.
Yes, sir, definitely.
yes, so I declare the session to be concluded. Thank you so much and good night.
Okay.